Hey, Steve, on one of your last slides, you showed that posterior wall fractures are the most common, and I think all of us would agree that they're some of the simpler fractures to fix, but they have the worst outcome. Why is that?
Thanks, Joe. Well, I think it goes to the illusion that Emile called them simple and complex fractures, but the simple isn't simple, right? The pattern, the anatomy of it in theory is simple, but often we didn't show an example of it, but often posterior walls can be multifragmentary, and they can be very hard to hold because the size of the fragments are often quite small. So I think all those things contribute to a late incongruence and failure of articular cartilage and ultimate arthritis.
Still no questions? Well, let's talk about fixing the sacrum. How do you guys work with the real trauma surgeons, the orthopedic trauma surgeons? Are you?
We take offense to that.
No, there's, like, in what sense?
Well, I mean, do you wait to be called, or does the ER call you, or?
Well, I think that in general, the orthopedic traumatologists are the gatekeepers for all of these injuries, right? And so I think in our group it's a little bit different because, I'll do both ortho trauma and spine. But I think in most places it's the traumatologist who is consulting their spine partners when they feel like it's necessary, right? And then there's always a discussion as to, or at least in my other places where I've trained, who goes first and that sort of thing. I think the priorities should always be the reduction, okay? And then when it comes to which is heavily reliant on the orthopedic traumatologist getting the pelvis reduced. And then when it comes to the instrumentation, I think there's always a push, like everyone wants to go first, but really we just need to think more about what are the corridors that are available and which corridors are the narrowest, and those should be instrumented first. So if the S1 corridor is the narrowest, then the S1 iliosacral screw just needs to go in first, and everything else from the spine hardware could be, shot around it. So in general, your spine hardware, there's a lot more play in terms of where we could place. So our iliac bolts, it's a pretty big corridor. You could shoot around other iliosacral screw hardware. But in general, the traumatologists are the gatekeepers for these injuries. But I think we need to recognize the advancements in percutaneous spine instrumentation because it offers some advantages that our traditional iliosacral screws don't offer.
So how many of us practicing in a community hospital have access to somebody who we have confidence can do a lumbosacral fusion? One of you?
Well, I think any spine surgeon who puts in screws should be able, especially with navigation, you can easily place L5 pedicle screws. And so the question is, how many people in community hospitals have access to a spine surgeon? Because once the pelvis is reduced by the trauma surgeon, then the instrumentation from a spine standpoint, it's a sawbones procedure.
Yeah, I appreciate you rephrasing my question.
Anytime.
I take it one step further. Many of us have spine surgeons at our hospital, right? But are they willing to come down to the emergency room or to the operating room to do this? And I got to tell you, in my 7 years in private practice, I'm not seeing it happen. So you're better off, in these cases, referring them on to a trauma service.
We'll see them here.
Yeah. Well, it's a long way from Tampa Bay. David, who should feel comfortable clearing a C-spine? Is it only the spine surgeons? Is it the emergency room guys, or us?
I mean, I think the initial clearance could be done by the ED or the trauma team. I think if there's any doubt, just ask the spine surgeons, and we're happy to do it. In some of those scenarios, it could sometimes be unclear whether the tenderness is midline, whether it's paracentral. If you're going to send someone out with the collar, you may want them to follow up with the spine surgeon just to make sure. I think it really depends on a person's level of comfort, the likelihood of the person following up. But at the end of the day, I'm much more tolerant of keeping someone in a collar for longer than removing one prematurely.
Yeah, I think that came across very nicely. Send them home in a hard collar.
Yeah.
And you have a lot of confidence in the Nexus criteria?
Yeah, I have a lot of confidence. And with my comment earlier with the soft color, when I said it's for decoration, I mean, I will sometimes put a patient in a soft color if I've cleared their C-spine. Yet sometimes they'll still have some soreness, or some patients are just scared to be around without a collar. And so if it comes from the patient and they want something and their C-spine is cleared, I will sometimes put on a soft collar, but never for actual treatment purposes.
Got it. Guile, who's capable of tackling these acetabular fractures other than the posterior wall?
I think it's someone that cares about it, because I've got residents that can come out and they're very good and they can do it. And some people, even after their trauma fellowship, shouldn't do it. So someone that cares about it and understands it, I think, is perfect for doing it.
Well, we've all done orthopedic residencies.
Right. And I believe that some of these, and it's funny because I've got residents who still call me and they'll say, this guy isn't so good. Is it bad for me to do him? And I said, no, you're very good and you understood it in residency.
And Paul, with regards to iliosacral fixation and percutaneous stuff, what if you're so old, what if I'm so old, I wasn't trained to do that? Can you get training nowadays? Are there places, does the academy offer that?
Yeah, I think part of the deal for all of us is you got to be a lifelong learner. No, you don't have to be. I mean, if you don't want to put iliosacral screws in, that's fine. But there are pelvic courses that are put on, and frankly, the fundamentals are. They're not actually that challenging. You need to understand the anatomy, what a dysmorphic and a non-dysmorphic sacrum is. That's actually not nearly as intimidating a topic as I thought it was. I thought it was this entity that could not be understood except by old people with gray hair and a lot of experience. It's actually very simple.
Why are you looking at me when you said that?
Reflex. But it's actually quite understandable, just like any anatomy. And if you want to know it, you can learn it at a course and do it with a colleague a few times and get comfortable, I think.
I would just like to point out, hair is not a requirement to understand that.
To kind of second Paul's point, before coming here, I was doing solely spine for about 4 years, and I did my trauma fellowship here and was able to learn it, and I will do them now as well.
Cool.
So it's never too late.
So years ago, before 06, we were using nerve monitoring intraoperatively. You guys using any nerve monitoring?
These guys do for spine. I don't do it for pelvis.
For the pelvis, sacrum?
And I think there's a study at the Harvard Review about the utility of neuromonitoring for pelvic ring injuries, and it just because they have their neurophysiologists are in-house,
Yeah.
And I don't really think it changed the course, if I remember that correctly.
How about if the patient has a neurologic injury when you're going into the operating room already from the injury? Are you still not using nerve monitoring?
I think the role of nerve monitoring for lower motor neurons, it only alerts you to injury after the fact.
Yeah.
So I think it has, I think when I look at the entirety of my practice, the utility of, I find nerve monitoring is most useful when I'm working at the level of the spinal cord or above, or at the locus of above, less so for, nerve roots, which is what we're working around with like for pelvic ring injuries and acetabular fractures in particular.
Yeah, the time we were using nerve monitoring, it was so painful. And then when we moved away from it, it was like...
Hey, Joe, just on doing some pelvic malunions, non-unions, I'm very worried when I'm going to lengthen them, when the whole hemipelvis is up. And unfortunately, I'm glad it happened during fellowship, but Joel, they said it was stone cold normal, and we had 2 people that basically woke up with a palsy.
Yeah.
So
that speaks to after the injury.
The sensitivity and specificity leaves a lot to be desired.
Yes, sir.
Is there any rule when you have a vertical shear injury, a small fragment in the foramen, you're going to take that fragment out?
So do you decompress the foramina?
I think you just need to use your judgment, right? So it just depends on, how invasive it's going to be to reach that fragment. Is it a fragment that's accessible? If it's a fragment that's only accessible from the front, most of us aren't going to go through the front because of the rich venous plexus. However, if you're doing an open posterior approach and you're looking at the foramen and it's and it's easy to retrieve, then I think you should decompress that nerve. You might run into a CSF leak, so you just need to know how to manage those. So I think you're weighing the risks and benefits for each specific patient.
And I also think if depends if the patient's symptomatic.
I always take it out. I'm more worried in someone that has a palsy before I start it. I've had one post-op. Fortunately, it resolved. But if I know I've got to bring the pelvis down acutely and I see some fractures there, I'm going to prefer to do an open. Yeah, you could maybe do it closed, but I open it and clean it out.
All right, it's 9 o'clock. I want to thank our presenters and the audience for participating.